How are you everyone? This is Jae-eun Jung from Seoul National University Gwanak Dental Hospital. I work at the Department of Periodontology. Today I will talk about the wound healing process in periodontology and then how we can apply the knowledge to the clinical situation for soft tissue management. The wound healing process proceeds 4 steps. First step is hemostatic phase. Second phase is inflammatory phase. Third phase is new tissue formation. And the last phase is remodeling phase. In the first phase, also it is called hemostatic phase, the blood clots are formed. As soon as the wound is created, platelets are released from unruptured blood vessels. Platelets release lots of growth factors, and fibrinogen and other chemotatic factors are combined to make provisional extracellular matrix. Provisional extracellular matrix is the start point to recover the structural integrity, and then granulation tissue is formed at the wound site. The granulation tissue will recruit the variety inflammatory cells into the defect. Then the second inflammatory phase starts. A dense inflammatory infiltrate composed of mainly neutrophils, which is round cells with either a green or orange-stained cytoplasm and polymorphic brown nuclei, which cleans up the tissue debris. And monocytes, round cells with brown or orange cytoplasm and kidney-shaped, which release complement and contribute to angiogenesis. And macrophage, which release growth factors to proliferate fibroblasts, endothelial cells, and epithelial cells. Third phase, about a week later, shows new tissue formation. This is a characteristic granulation tissue invading the wound space. Small blood vessels can be seen, comprised of endothelial cells, which is pointed arrow, green-stained collagen fibers, and purple-stained oxytolin fibers. And there are many containing RBCs, which is indicated R in the lumen. Most cells in the matrix are leukocytes, but scattered fibroblast-like cells are present. And a few days later, epithelial cells are observed in the granulation tissues too. 2 weeks after the wound formation, remodeling phase starts. Well-vascularized collagen-rich dense fibrous connective tissue has replaced the regions of the granulation tissues. The regions surrounding the dense connective tissue also appear fairly rich in collagen fibers. This scar-like tissue is well vascularized. Coronally, regions of granulation tissue remain. In other words, the well-vascularized collagen-rich connective tissue means fibrous repair. It means newly formed tissue resembles scar and it has long-term stability. As you see before, the wound healing phase proceeds like this. First, the clot formation phase, and second, matrix formation phase, and third, tissue formation phase. And the collagen are accumulated in the matrix. The final maturation stage occurred. To promote the healing of wound, there are 4 factors influencing the wound healing. First, closeness of the wound edge adaptation. Second, adequate blood supply to wound site. And third, reducing the infection. And last, the tissue displacement should be minimum. It means the wound stability. Fibrin clot is very important for periodontal wound healing. In Vicious study, circumferential periodontal defects approximately 5 mm in vertical dimensions were surgically created and immediately treated around the mandibular premolars in 4 beagle dogs. Prior to wound closure, the root surface were treated with either the anticoagulant heparin or with saline. Tissue blocks were obtained as sacrifice 4 weeks after surgery. Histometric analysis showed that connective tissue repair to the root surface averaged 50% of the defect height for heparin-treated teeth as compared to 95% for saline-treated teeth. It can be concluded that the heparin treatment of the root surface compromises connective tissue repair, confirming that blood clot adhesion as one prerequisite for connective tissue repair of periodontal defect. Wound stability is important in wound healing. In periodontal wound healing, blood clots should be attached to the root surface to promote the new connective tissue attachment. The resilience of fibrin clot increased by time, and until 1 month after wound formation, the clot cannot be removed from the tooth surface. In other words, maintaining stable fibrin clot in periodontal wound is a critical factor of healing. And you should remove your suture material after 2 weeks of surgery according to the fibrin clot adhesion. So to stabilize fibrin clot, we can apply pressure with wet gauze and make each side of flap adapt closely. And this can be decreasing the postoperative swelling and promoting the hemostasis of the wound. There are 3 factors influencing the wound stability: tension applied to wound margin, and thickness of the flap, and inflammatory cells can be infiltrated up to the 3 mm from the incision line, and this can be reduced the blood supply. So we should consider this: the suture should be made at least 3 mm from the incision margin. We should always consider that the suture can be a trauma to the wound site. As you can see in this figure, around the suture material, inflammatory cells infiltrated up to 0.5 mm, and the inflammatory infiltrate region is larger as silk material than Gore-Tex suture. The result revealed that placement of sutures in gingival tissue elicits an inflammatory reaction, and that the magnitude of this reaction may vary with the suture material used. Braided silk suture apparently cause a more extensive inflammatory tissue reaction in an environment characterized by moisture and infectious potential. Second, flap thickness is also important. According to a Welfle's study, if the flap tension is more than 15 grams, 100% wound dehiscence was observed at the wound site where the flap thickness was less than 1 mm. Therefore, in thin biotype patients, we should be more careful to avoid the dehiscence of the wound. The flap should be advanced more coronally without much tension, and the smaller diameter suture material will be a good choice. This figure shows tensile strength of wounds plotted over the time. The dotted yellow line for the flap and bone interface from 10 days onwards indicates that tensile strength of some flaps exceeded that of the attachment of the suture to the flap. Tensile strength was seen to increase with the time for both interfaces, with the tensile strength of the bone and flap interface showing higher values for all time points. The tensile strengths for the dentin interface were less than half the values seen for the bone interface at the all time points up to 7 days. It means that there is no blood supply around the dentin, unlike bone. We need almost 3 weeks to get enough tensile strength to flap and root surface interface. We can make conclusions like followings. Epithelial healing followings, periodontal treatment appears to be completed after a period of 7 to 14 days, and structural integrity of a maturing wound between denuded root and flap is achieved at approximately 14 days. Formation of the biologic width and maturation of the barrier function around transmucosal dental implants requires about 6 to 8 weeks. As we have seen before, the tension-free suture of the flap in periodontal or implant surgery is very important factor in wound healing. Main purpose of suture is passive adaptation of flap margin and mechanical stability of the flap for wound stabilization. There are 3 patterns to position the flap margins. Theoretically, the right one, the positional suture patterns are preferable as they allow the anatomical approximation of the tissue plane. Inverting patterns are usually used in gastrointestinal surgery field, but in dental field, everting suture patterns are used because the implant areas often require dispersal of tension force along the wound closure line. So, how we make perfect suture? These are main principles. Pierce the flap surface with the needle perpendicular to the flap, and the piercing point should be located 5 mm away from the flap margin. The suture should go from movable tissue to non-movable tissue, and do not touch the alveolar bone or tooth surface to prevent the needle tip bend. The simple interrupted stitch is a suturing technique used to close wound. It is the most commonly used technique. Placing and tying each stitch individually is time-consuming, but this technique keeps the wounds together even if one suture fails. It is simple and relatively easy to place. It is used to reposition the flap and position the flaps coronally. Anchoring suture uses the tooth, implant, masticator mucosa or connective tissue or vestibules like an anchor. Needle placed at the lingual area of the flap adjacent to tooth, anchored around the tooth passed beneath the opposite flap and tied. It is useful to close a flap mesial or distal to a tooth, for example in distal wedge procedure, and close the facial and lingual flaps and adapt them tightly. The main advantage of continuous suture is the speed, because we just make one tie in the long wound area. But main disadvantage is that if the suture breaks in one point, the flap may become loose or suture may untie from multiple teeth. The continuous sling suture is used to adapt the buccal and lingual flaps without tying the buccal flap to the lingual flap. The teeth are used to suspend each flap against the bone. Continuous lock make wound margins approximation with successive loop. The advantage of continuous locked suture is useful for long edentulous area, and it has the advantage of avoiding multiple knots. There are friction points, it means locks, along the suture to reduce the tendency of suture to loosen when placing the rest of the suture. Thus, the locked stitches have to hold the previously placed portion of the continuous suture tight. Unlike continuous suture, if one suture breaks, the flap may keep the position during healing because of the locks. This is metal suture. This is a special type of suture and is described as horizontal and vertical. Its indication in cases where strong and secure reapproximation of the wound margin is required. They also allow for good papillary stabilization and placement. This is vertical metal suture. I usually use this type of suture technique when GBR is done because this technique can help everting the flap margin. This is how we do the vertical metal suture. The needle passes at 2 levels, one deep to provide support the wound surface at a depth, and one superficial to draw the edges together and evert them. Needle passed from one edge to the other, and again from lateral edge to the first and not tied. When needle is brought back from second flap to the first, depth of penetration is more superficial. You have to remember the far, far, and near, and tie. You can also use modified vertical metal suture. It is called Ora-Aid suture. The principle is just same as vertical metal suture. Needle passes far, far, near point, and before making the tie, the needle goes through the loop here. This method is characterized by an inverting and everting portion, ideal for interdental tissue closure. Horizontal matrix suture is strongest type of suture. This is used in large distance between tissues, closure of bone graft in implant sites. This can evert the much amount of the flap in surgical area, but sometimes the depth of the vestibule can be very shallow. But this suture can leave a gap between flaps. You have to add a simple interrupted suture along the flap margin. Personally, I use applied horizontal matrix suture to secure the barrier membrane for GBR under the flap. This suture can press the membrane that covers the grafted bone, so it can eliminate the dead space between a graft and membrane or underlying bone and graft materials. Figure of 8 suture patterns goes like this. This is usually used for extraction socket closure and also used for adaptation of gingiva papilla around the tooth. This suture induces a rapid closure of the wound, but due to its orientation, it is difficult to remove and it leaves a significant amount of suture threads inside the socket. And the other drawback of the figure of 8 suture is that this suture pulls buccal and lingual side of flap too tightly. So after completion of the healing, as you can see in this picture, the extraction site can shrink a lot. So to prevent this shrinkage of the tissue, the hidden X suture proposed by Dr. Park Jung-cheol in Kyung-hee University. This is conventional figure of 8 suture. X suture, the needle passes through over the extraction socket twice as it performing a continuous suture. A large cross-X is created over the socket after suturing. The blue arrow indicates the pulling vectors created by the X suture. But in hidden X suture, the needle enters the buccal flap and passes to the opposite side in a diagonal direction. Then it passes again from the buccal to the lingual side, also in a diagonal direction. A crossed X is created under the flap, unlike the X suture or crisscross suture. The blue arrow indicates the vectors created by the hidden X suture. These are the healing of the hidden X and X suture. In hidden X suture site, there is a minimum tension along the buccal-lingual axis, so there is a reduced loss of keratinized gingiva. And it can hold the graft or membrane in the extraction socket well. This technique is very useful in the socket preservation cases. Now let's review the suture materials. There are absorbable and non-absorbable suture materials, and also braided and monofilament materials. How do we choose the suture materials? Because the purpose of suture is to maintain the structure integrity during the wound healing phase, the suture material should be maintained longer in root surface than alveolar bone, because there are differences of blood supply. And if you want to maintain the suture material longer, monofilament suture material are better, because much plaque can attach to the braided suture materials. I usually use 5-0-ethylene for the implant surgery or periodontal surgery. This is monofilament non-resorbable suture materials and has excellent strength and less tissue reactivity. These kinds of monofilament suture, like nylon, ethylene, Defilone, are more difficult to handle or make tie because there is little friction in the suture material. And 4-0 nylon suture can irritate or abrade the oral mucosa around the wound site, so I recommend to use 5-0 nylon or ethylene suture in periodontal surgery. Every suture material reveals the information of needle on its cover. 12 to 13 mm of needle length is suitable for mucogingival surgery, and longer needle, maybe 17 or 18 mm, is suitable for periodontal flap surgery. Cutting edge can be tapered, reverse cutting edge, and round. Reverse cutting edge has high efficiency. That means it can pass the flap easily and tie does not make flap tearing when we pull the suture to make knot. And needle diameter is matched the suture size to minimize the tissue damage. Choosing the finer suture material may reduce the trauma on the tissue, but the difficulty may increase. First step to obtain the favorable healing is to design a flap. So good flap design can obtain a good visibility. Do not compromise the blood supply or aesthetics, especially in the interdental papilla area. The incision line should not be designed in a direction transverse to the direction of blood vessels. And good flap design also allows the passive adaptation of flaps. Finally, incision line cannot be designed over the bony defects because it is hard to reflect the flap cleanly because of the granulation tissue filling the defect. In maxillary area, anterior buccal parts get blood from the facial artery and infraorbital artery. So when you make a flap design in maxillary anterior area, especially maxillary buccal area, please confirm the infraorbital artery direction. The infraorbital artery passes like this. So if we cut the blood supply transversely, for example, in semilunar coronally positioned flap surgery, there would be scar because of the blood supply was cut. You can check the scar in this picture after healing. Horizontal incision should be made in keratinized gingiva because of less bleeding, fast healing, and less pain. Usually in maxillary area, slightly palatally positioned horizontal incision is favorable in the first picture of this slide. And this palatally positioned incision line can be a reference line for an implant position, and the operator doesn't need to retract the thick palatal flap to get the enough visibility. And in mandibular area, crestal incision is favorable to maintain the keratinized gingiva and lingual side. Look at the blood supply of the mandibular area in the corner of this slide. If the horizontal incision is located on the buccal side, the postoperative bleeding or swelling will increase. Unlike maxilla, mandibular lingual flap is easily detached from the bone and the retraction is easy too. The simple incision is the best incision. Crestal incision is not enough to open the flap and secure the operative site. Additional vertical incision or circular incision should be done. Circular incision is easier to suture than the vertical incision, but circular incision only gives the limited mobility of the flap to coronally and limited visibility too. So if the bone graft is accompanied by the implant procedure, circular incision is not suitable. In maxillary anterior area, we can modify the circular incision to preserve the interdental papilla like in this figure. Then the problem like black triangle will be minimal. Vertical incision is able to localize the surgical field and mobilize the flap, but it is more difficult to suture and postoperative pain can be increased. Vertical incision can be made at mesial line angle, distal of adjacent tooth and distal line angle of the second next tooth. Vertical incision at distal adjacent tooth is the commonly used one, like in the second picture. First suture the crestal incision and then vertical incision with simple interrupted suture or ankle suture. It is easier to reposition the flap around the vertical incision. But in case of GBR, the incision line should be placed about 4 or 5 millimeters apart from the bone graft site. So you have to choose the number 3. Suture must be done at the interdental papilla first in this case. In many cases of implant surgery, The regeneration technique such as GBR is accompanied by implant placement. For successful GBR, primary closure is the most important thing. And for primary closure, we have to advance the flap coronally. How can we achieve the flap lengthening? Flap can be advanced about 1 mm by 1 vertical incision and 2 mm by 2 vertical incisions, and 5 mm by periosteal releasing incisions. So, periosteal releasing incision is the most efficient method for flap lengthening. Periosteal releasing incision should be toward outside with new blade. To make the incision toward outside, you have to pull the flap outward and then make the releasing. The adequate depth of periosteal incision is 0.5 mm. If it is too deep, many blood vessels are cut and postoperative bleeding and swelling will increase. At last, I want to introduce the new periodontal mucoadhesive dressing, Ora-Aid. The periodontal dressings are applied around the teeth and adjacent periodontal tissue to protect surgical areas, reduction of infections, pain, and sensitivity after periodontal surgery. When you hear the word periodontal dressing, the first thing that comes to mind is a product called Copac. Copac is the most widely used non-eugenol dressing and consists of two components, base and catalyst, containing bacteriostatic agent. Copac is free from tissue irritation and has good adhesive properties, but it has poor appearance, bulky volume, and ill-defined setting time. So, to overcome these drawbacks of Copac, a new mucoadhesive periodontal dressing called Ora-Aid was developed. Ora-Aid is a dressing system comprising a mucoadhesive layer and backing layer and provided attached to a thin film. The protection side is an outer surface of the dressing and to protect the wound area from the outside for about 12 hours of contact duration. And the attachment side is an inner surface that attaches to the gingiva. This part is attached to the wound for 12 hours of contact duration. The inner attachment side is consisted of water-soluble polymer. Attachment side has a strong adhesion when it is applied on mucosa and reacts with water and saliva changes into a gel state. The outer protection side is consisted of water-insoluble polymer. The polymer on the protection side covers the wound to protect the wound from the external stimuli, for example, bacteria, saliva, and any other trauma. Then, how do we apply this mucoadhesive periodontal dressing? First, we trim the dressing according to the size of the wound. Second, remove the excessive saliva and blood by the gauze. Last, adapt the dressing to the wound and press it for about 10 to 30 seconds. It's so simple. This case is gingival depigmentation and the application of Ora-Aid. Trim the dressing and make the notch at dressing to secure the space for labia frenum. Apply the dressing and push it for about 10 to 30 seconds. The application method is so simple and easy. This case is alveoloplasty. The surgical field and technique is very similar to conventional flap surgery. After suturing, after suture is finished, trim the dressing and some cuts are made on the dressing to allow the tooth curvature when dressing is applied. Place the dressing at the surgical field and push it for about 10 to 30 seconds. The last case is for implant. The incision is done and drilling and the fixture placement was done. And graft material is applied. After the suture, trim the Ora-Aid as usual and apply it to the surgical site. It can protect the implant site very easily. Let's look at some more clinical cases using Ora-Aid. These two cases are aesthetic clinical crown lengthening procedure. After resective surgery and suturing, Ora-Aid was trimmed according to the length of the surgical site. As you see here, notch was formed to avoid the labia frenum area. Ora-Aid was adapted to the buccal side and pressed for about 10 seconds. Please check the uneventful healing here. Ora-Aid can be applied to the both recipient and donor site in free gingiva graft. The mucoadhesive dressing stabilized the blood clot at palate area and will dissolve in a day. I usually used Copac for palatal donor site before, but patients had discomfort by the bulkiness in the palatal area. The use of Ora-Aid greatly reduced the patient's complaints of the discomfort. The application of periodontal dressing is still controversial. Some says there is no positive effect on healing. Sometimes delayed wound healing occurs because of the plaque accumulation, and some says there is more pain. But others says periodontal dressing can protect the wound from the trauma, enhance the stability of surgical site, and even shows positive effect on long-term result. So we perform a clinical trial to figure out the effect of mucoadhesive periodontal dressing. We recruited 35 subjects and each subject underwent periodontal flap surgery at 2 quadrants. One quadrant assigned to group 1 and Copac was applied, and the other quadrant assigned to group 2 and Ora-Aid was applied. We assessed clinical parameters like gingiva index, periodontal pocket depth, and postoperative discomfort and pain. According to clinical assessment, there were no significant differences between the two groups on day 0 and day 14 for gingiva index, gingiva recession, and proving pocket depth. Gingiva index and proving pocket depth decreased significantly on day 14 in each group. Gingival recession is increased at day 14 in both group 2. But there was significant difference according to postoperative pain. Ora-Aid group showed significantly lower score of visual analog scale 1 day after the flap surgery. Look at the difference between two groups. And most sites in Ora-Aid group showed VAS score 0 or 1 at day 1. According to postoperative discomfort, only for eating discomfort, Ora-Aid showed significantly lower score than Copac. And we think this is because of the bulkiness of Copac. As we confirm in this research, the advantages of mucoadhesive dressing are less pain and discomfort, less time required, no limitation of working time, and superior aesthetics. So it may be concluded that the adhesive periodontal dressing, Ora-Aid, is easily applied, shows more aesthetic appearance without unpleasant taste or smell. The clinician's personal preference as well as the patient's acceptance, like postoperative pain or discomfort, are important while deciding the periodontal dressing of choice. With due consideration to the above, Ora-Aid can be an alternative to Copac as a dressing material. Thank you for your attention. If you have any questions or comments, please contact me with this email. Thank you.